All right, so my name is Emma. I am a fourth year medical student, just about to graduate here soon, for better or for worse, in a couple weeks. But today what we're gonna do is we're gonna talk about um, dyspnea, which is essentially a fancy way of saying shortness of breath. Okay, so that's what we're going to talk about. We're going to kind of go through, and you'll start to learn really that shortness of breath can be multifaceted. So obviously, when we think shortness of breath, we think the lungs, but that it can be really associated with, we'll find cardiac things. It can be caused with hematologic things like anemias, many different things, infections. So we'll kind of go through some of those things. We'll talk about them. And then we'll also, kind of go through a workup and how you can kind of approach this. Okay. Here in the chat, I just put a link in there. That's for the SOAP note and everything that you'll kind of use in terms of the quiz, all of those things, the resources for this presentation. Okay. So I love this little like meme. I laugh at it every time I see it, but you guys may not get it if you don't know the anatomy of the actual like stomach and the GI tract, but essentially it is. See, Adam gets it. So essentially, what it is it's a branch of a branch off of the aorta that supplies the stomach. It's not the aorta. So I always laugh really hard at this. But let me launch the pre-poll for you guys. And what I want you to do is kind of select, what you and kind of gauge what you know about dyspnea, what you know about shortness of breath. All right, so I think most of you guys are in there. So it looks like a few of you said, one of you said that you know some, which is great. But it looks like most of you kind of lie in the nothing category, or a little bit, which is great. We'll see if we can't teach you something tonight about shortness of breath. All right, so I'm going to stop sharing that here, and we're going to keep going. All right, so this is our kind of outline, and if you're new this week, no fear. We're going to kind of go through things, and first we'll kind of go through, the outline, what we're going to do. So basically, what we're going to do today is we're going to talk about shortness of breath. I'm going to give you a case that I created myself, and then after that, we're going to kind of go through a summary of what shortness of breath is. And what I'm going to ask of you guys is that you kind of participate, but also one of you I'm going to ask to read the case. And then throughout the presentation, what I want you guys to do is fill out that SOAP note, that link that I put into the chat. And we'll talk here in a couple of slides about what the actual SOAP note is. And then after you're done, you'll complete a quiz that I also created. And I kind of pride myself in making easy questions for you guys, because you guys aren't getting, college credit for this. So I'm not giving you hard questions. They're pretty reasonable questions that if you are able to answer, or if you are able to, pay attention with a little bit of attention to the presentation, you should be able to complete that quiz with ease. Okay. All right. Let me clear all this and we'll keep going here. So here's the SOAP note as promised. And what it kind of stands for is it's an acronym. Okay. So it stands for subjective, objective, assessment, and plan. Okay, so What is subjective, as you know, kind of based on the definition of the word, it's things of which, in medicine, things of which the patient's telling us. So that's the history of present illness. So kind of the narrative of why the patient is presenting that day. But also the ROS, which is pertinent positives and negatives relating to that chief complaint. Okay. And you know, for instance, if somebody's showing up with shortness of breath, it might be things like, are they having chest pain, or is the pain worse when they take it, or if they do have chest pain, if the pain is worse when they take a deep breath, or you know, is there chest pain, or is there shortness of breath at rest, or only when they move? So things that are pertinent positives and negatives relating to that chief complaint. Okay. Then the objective portion is things that we're going to find. So you're going to see in this case, I've created one case today as opposed to my kind of multi cases that I do some weeks. But the vital signs and physical exam. So these are things that we're kind of finding, that we've produced, that we're, you know, finding out about the patient. Then finally, we're going to get to the assessment and plan. So, you know, say somebody comes in with atypical chest pain. So that's our assessment of the patient. The patient came in with atypical chest pain. And what is our plan? What are we going to do for the chest pain? Or what is it? We might say likely costochondritis, which is kind of inflammation of the chest wall. Likely costochondritis. We've ruled out acute coronary syndrome. Then what are we going to do about it? We might say treat with NSAIDs as needed. Okay, so basically what we're doing is we're listing what's going on and then what we're going to do in order to treat that. Okay, good. So let me clear this and we'll keep going here. So the first thing that we're going to kind of talk about is this idea of delineating dyspnea, shortness of breath, by chronic and acute dyspnea. So acute meaning anywhere from it just started to, you know, about a week, and chronic meaning it's gone over time. Okay, so that's a little kind of vocab essentially first off the bat. But often when it comes to shortness of breath, we really delineate the shortness of breath based on different you know, organ systems. So that's what we're doing here. And I like this figure because it kind of delineates based on pulmonary and chest wall. And that's probably the things that you guys think of, you know, right away. You may think of asthma or COPD right off the bat, or pneumonia, or things that are really actually going on with the chest. All right. And then other things that we may think about are things like cardiac. We may think of things with the head and neck. We may think of abdominal. Other things like neuromuscular. We may think of toxic and metabolic things, or even psychiatric things. And you are probably starting to get the impression that dyspnea, shortness of breath, is really kind of far reaching. There's lots of things to kind of talk about when we are kind of talking about shortness of breath. Okay, so the first things I want to kind of draw your attention to in terms of pulmonary and chest wall are the idea of these acute things kind of over here. So obviously if we have trauma to the chest wall, that can certainly cause shortness of breath. You'll see asthma. We can have an asthma kind of attack, if you will, asthma exacerbation. You can see it on both sides, obviously acute asthma exacerbation and COPD exacerbation, but also we can kind of see it in this chronic side too. Okay. And then other things like pneumonia, that can be acute, obviously. We can have chronic pleural effusions and acute ones. You'll see some that are kind of on both sides. Then other things, and you guys may think of this, but kind of lung cancer, okay? That can cause shortness of breath. Oftentimes, lung cancers are kind of picked up incidentally on a CT or chest x-ray. And now, in terms of cardiovascular, lots of things that can cause it. Something that we kind of think of and we want to include in our differential for shortness of breath is heart failure. And that's exactly what this kind of this abbreviation is right there. So what that is heart failure. That's what that is, HF. And then we either define it as preserved ejection fraction, or reduced ejection fraction. Okay, that's what that kind of HFREF. So we call it like HFrEF, HF, essentially. So when we kind of delineate that, and what the ejection fraction is the amount of blood really being pumped in the heart at a certain period of time. And that's what we kind of used as a kind of marker to kind of show whether the heart is functioning well or not. And you may be sitting there asking, okay, well, what is a normal ejection fraction? And that's usually anywhere from about 55 to 65%. And when we get down to kind of this reduced ejection fraction, you may see really sick people with ejection fractions of 11%, of 20%, 33%. I'm in cardiology right now, and we have sick patients on the floor of whom have ejection fractions of 10, 11%, and who are pretty sick, and you'll see them short of breath, and pretty cyanotic and have mottled feet and things like that. Okay, so good. Now, what other things can cause it? You guys probably have it in your kind of thoughts, your differential, especially if you work in the emergency department. But that is acute coronary syndrome. And what that is kind of pointing us to is myocardial infarction. Okay. A lot of times you'll see patients come in who are having a heart attack. They might say, I had chest pain and I felt really short of breath. I felt like the pain kind of took my breath away. All right, other things like arrhythmias. So AFib, people will often kind of feel palpitations, they'll feel short of breath. All right, other things, cardiomyopathies, obviously. What is a cardiomyopathy? We might see one later on where the chambers of the heart are dilated. And so that's called a dilated cardiomyopathy. That's a horrible rendition of the heart. Here's the atria, and then there's the ventricles. But when those chambers get dilated, it's not pumping as well. And when the heart's not pumping as well, fluid gets backed up into the lungs. Okay, you can get pulmonary congestion, you can have a pleural effusion, things along those lines. Okay, now other things, what else can cause it? Obviously, anaphylaxis can cause it, angioedema. If you have an infection, tumor, head and neck cancers can cause it. If you have a goiter, that can also cause shortness of breath, because as you can imagine, if you have a goiter of the thyroid, and we've talked about this in the thyroid lectures in the past, if we have a goiter, it can be kind of swollen. As a result, it can kind of impinge on your structures in the neck, the trachea, things along those lines. Then obviously abdominal things. If you have ascites, you could have ascites for a number of reasons, but one that kind of often occurs is cirrhosis secondary to liver disease. So remember, liver disease has multiple flavors. You don't have to drink a lot of alcohol in order to have liver cirrhosis. We know that if you have non-alcoholic steatohepatitis, NASH for short, or you might see it also abbreviated as NAFLD, which is non-alcoholic fatty liver disease. We know that if you have that, you're setting up a good environment for your liver to be exposed to a lot of inflammation, and correspondingly an environment in which you can form cirrhosis of the liver. So you get scarring of the liver. First, you start out with the big nodules of the liver, and then slowly get down to smaller nodules and kind of late stage cirrhosis. Other things that can cause it: obesity, hypoventilation syndrome. If you have a lot of adipose tissue in your abdomen, you correspondingly inhibit your body's natural ability to get big tidal volumes into your lungs. And so as a result, you can have shortness of breath. You can feel short of breath, especially if you have a higher demand. Other things, strokes can cause it. If you have problems with the diaphragm, say you have a surgery and you know, something happens to the phrenic nerve, or you have you know, a lung tumor that inhibits the recurrent laryngeal nerve, or something that touches the phrenic nerve, we can have shortness of breath as a result of that. Other things, toxic metabolic, you could get it from fever, sepsis, diabetic ketoacidosis, and then psychiatric, you could get it with anxiety as well. Usually what we see with anxiety is kind of hyperventilation. So there'll be things that point us in that direction, like blood gases. We'll see a low CO2. We might see, because they're blowing off more CO2, they might be alkalotic. So you might get a respiratory alkalosis. Remember, CO2 is a gas. Okay, so as you could probably see, the workup for shortness of breath is pretty multifaceted, okay? There's lots of things to talk about here, but let's keep going here in terms of what we're gonna do if a patient comes to you with shortness of breath. Okay, so if somebody comes to you with shortness of breath or presenting, you know, maybe acutely in the emergency department, and they say, I'm short of breath, you know, obviously what we want to do is we want to get a history. So this is our HPI here. We're saying, okay, what's going on? Is this when you're at rest, which is a lot different than, you know, I get short of breath when I'm walking up a hill. They may be deconditioned, meaning, you know, maybe they just had surgery and now they're short of breath because they're not used to that sort of activity. Other things that are important is position. You guys may remember from when we talked about heart failure in the past, if they get short of breath when they're lying flat, we call that orthopnea. And that is often indicative of heart failure, okay? And then other things is, should we take SOAP notes when we're reviewing the case or throughout the presentation? Good question. So that's going to be when we go through the case. Right now, I'm giving you kind of a little bit of an introduction to the actual shortness of breath, and then we're going to go through a case. So great question. So after that, when we kind of have this patient with shortness of breath, we obviously want to get a physical exam. So things like what they look like generally. Are they speaking in full sentences? Are they using accessory muscles? So maybe belly breathing a little bit. Their color, are they cyanotic? Are they pale? Other things, are they breathing fast? Do they have pulsus paradoxus? Are they... when you're looking at their O2 sats, are they short of breath, but they have a good O2 saturation? Other things, when we're auscultating, we're listening to the lungs. Do they have wheezes? Do they have crackles, which are called rales? Do they have decreased breath sounds, which could indicate to us maybe that there's fluid in the lungs? Do they have a barrel chest, or do they appear hyperinflated? That might point us in the direction of COPD. Other things, do they have elevated JVP, jugular venous pressure? So maybe when we press on their liver, do we see kind of the rising of their jugular veins, which could tell us about their fluid status? Do they have murmurs? Do they have gallops? Do they have edema, which could tell us about if they're in a fluid overloaded state? But in this diagram, what they're telling us is, okay, at this point, based on a physical exam and a history, the diagnosis could be evident, but we're going to get other things. Here, this says, you know, we can get a chest radiograph. And what we're looking at is everything we would look at a chest x-ray otherwise, which is things like, we're going to look at the cardiac silhouette. We're going to look at the lung fields. We're going to see if anything's evident. Is there interstitial patterns? Is there hyperinflation? Is there pleural effusions? Anything like that. And then, you know, say we see kind of a large heart and evidence of fluid overloaded, such as like a pleural effusion. That might point us in the direction of a low cardiac output. And in that point, we might want to get an electrocardiogram, look at the electrical activity of the heart, and an echo to kind of see the functionality and look at that ejection fraction of the heart. Other things that we could certainly look at are we can look at the actual gas exchange of the lungs. So in that regard, we might look at pulmonary function testing. So basically what we're looking at there is the patient's ability to actually take a deep breath, their tidal volume, which is what they do at rest, and their ability to inhale, exhale, all of those things, because that can point us in the direction of restrictive versus obstructive lung diseases. Okay. Then other thing is if they have high cardiac output, which is the opposite of, if we have a heart failure with reduced ejection fraction, we might think of something like anemia. We might do thyroid function testing because we can have a high cardiac output in hyperthyroidism. And then other things that we might do is if the diagnosis is still uncertain, we might do cardiopulmonary exercise testing. So we might do a stress test or things along this line. But as we start to work these things up, you're going to see that it's going to be a little more evident. Okay. And the case that I'm giving you guys today, it's a fairly quick one. That's why I'm spending a lot of spending a lot of time in this introduction, because it's going to be a fairly quick case here in the beginning. And I think you guys will get it. All right, so here's our case, okay? So we have a 33-year-old gentleman. He's presenting today, and this is where you can start taking your SOAP note, okay? So here's a lot of history, as we talked about. This is probably a little more subjective over here, and then here's our objective part, okay? So what we're really honing in on right now is the case presentation. So basically what is coming to us is a 33-year-old guy presenting to the emergency department with an acute onset of shortness of breath. So remember, we're delineating already, this is acute, so it just started. He notes that he was sitting watching TV when he felt an acute onset of shortness of breath. Family history is significant from his father dying from a thoracic aortic aneurysm. Okay, so what other questions do you guys want to ask this guy?
Well, I want to ask him, did the shortness of breath happen before? How long has he had it? And has he had any of the other symptoms related to it?
Good. Okay, so we'll say he just got it very quickly. Does it happen only when he sits down? Exactly. So he was just sitting, watching TV. He's never felt shortness of breath before. He's usually pretty active. He plays basketball and usually never has shortness of breath. Good questions. Is he a smoker? No, he doesn't smoke. Does it happen only when he sits down? So it just happened all of a sudden when he was sitting down. He wasn't short of breath earlier. Did it get worse when he stood up and walked around? Yes, it felt like he wasn't able to walk to the car and had to walk really slowly to get to the car to come to the emergency department. Increased stress. No, he's been fairly not stressed. He's out of school for the summer. He's in college right now. Does he have scoliosis? I would say yes. So here is, you guys are probably looking at it right now. Here's the picture of our patient. So he has a little bit of scoliosis and maybe some issue with the chest wall here, pectus, pectus something. I'm blanking on the word right now. But he looks like he does have a little bit of a scoliosis there. Recent weight loss, no, he's always been a skinny person. Good questions. Anybody else have any other questions you want to ask this guy?
I guess, has he ever been diagnosed with high blood pressure or high cholesterol?
Yeah, that's good. Good questions for in terms of the history. Good.
Thank you.
Excellent. Anybody else? Any surgeries? We'll say no surgeries, no recent infections, no change in diet. Good. You guys are asking all good questions. And then while we're while we're talking about it, this patient has a history of his father having a thoracic aortic aneurysm. And you may not know what this necessarily means, but you guys will know from your anatomy course that the aorta kind of goes like this, okay? And we delineate it. So here's the iliac arteries down here, and we delineate the aorta by its thoracic area and then its abdominal area. So we know that when it gets kind of in, you know, past the diaphragm, we call that the abdominal aorta, and then up here is the thoracic aorta. So we don't know much about it. We don't know if it was a type A, which is ascending, so it's usually kind of in this area, an ascending aorta aneurysm, or if it's a type B, that's usually a descending aortic aneurysm. So kind of in this area down here.
Mm-hmm.
So perfect. You guys are on the right track here. So let's clear all this junk out of the way, and let's focus on the physical exam now. Because this patient is, would you guys say pretty sick? Is this emergent? Is this the type of patient that you're going to get in triage and want to kind of get back right away? What do you think?
Not really, because just besides the chest pain, he didn't have any other aneuritic symptoms. Like he had no stomach pains, dizziness, nausea. So I wouldn't totally put him in triage first, but I'd definitely get an EKG on him when I get him.
Okay. All right. Perfect. So let's kind of go through this. And you guys tell me if you change your mind in terms of if you want to do something about this patient. So this guy is, he is talking to you, or gave you a history, but he's tachycardic. He is hypotensive. He's in acute distress. That's what we said. We listened to his heart and we said that he's tachycardic. His heart is going really fast. He doesn't have any JVD. Okay. So when we look at his neck veins, we don't see kind of the pulsation of his jugular veins, indicating perhaps fluid overload. Noting that his blood pressure is pretty low, I would send him back more urgently. Yeah, especially if he's hypotensive in the face of tachycardia. So he has a good response to his hypotension, but you're right, I would send him back a little bit quicker too. He has decreased air movement on the right side with tachypnea, and tachypnea means he's breathing kind of fast. Okay, he has hyperresonance to percussion. So what we're doing is, you may have seen doctors do this at this point in your education so far, is what you're doing is you're using your hand as a hammer and you're kind of percussing like this. You see it often on the abdomen. We use it in percussion on the lungs too. And you could do this to yourself. For instance, you could do it right now. So what you're doing is you're using kind of your knuckle, your DIP, or your even part of your your PIP, and then, or I'm sorry, your DIP. I'm like all over the place. So DIP, I use my middle finger personally. And what you can do is do it on yourself right now. You can do it on your quad right now. When you percuss there, it should make a different sound than when you percuss, for instance, on your abdomen. And try this, and you can do it to do it to your your roommate, and do it on their lungs and do it on their belly, and you'll feel kind of the percussion changes. One side that you can see it pretty notable in is when you percuss around the liver. When you percuss the liver edge, you'll hear it, that kind of change in tympany, basically. So when you percuss your leg, that should be different than when you percuss your own abdomen. And that's the point here when we're doing percussion on the lungs. If it's hyperresonant to percussion, that means it's louder. Okay, when it's not as loud, that might point us in the direction of fluid being there. When it's hyperresonant, what might that tell us, guys? What do you think? Knowing what you know now about percussing the lungs, what would you think in terms of percussing and it's louder?
Are the lungs like inflated, maybe?
Yeah, exactly. Great point. You're absolutely right, Brenda. I agree with you 100%. That's exactly what that is. So knowing what you know, if you percuss the liver edge and it's a little duller when you percuss, you say, okay, that's solid. If you percuss, a belly, for instance, with ascites, let me draw it out for you guys here. If you have a patient and their head is kind of up here, here's their belly, and you're percussing, and they have a lot of fluid in their abdomen. Another test that we do. So here's a bunch of fluid, and here's air. We know that the air is going to rise. A test that we do is we kind of percuss on the top. You'll hear it hyperresonant because that's air. You'll percuss around, and then it will be dull down at the bottom where the fluid is. And something that we do is we have them roll on their side and then do it again, because the air will shift to the top. That's called shifting dullness. Okay, so the fluid will go to the bottom, air will go to the top. So that's another thing for kind of perspective in terms of this. Now, the patient has no tenderness to palpation, no masses, no hernias, no edema to the lower extremities bilateral. The patient is unresponsive. So whoever pointed that out, you're right. Hyporeflexive and in both the brachioradialis and the patella. So I would say that we need to get this patient back a little bit faster. So Brooke, you're absolutely right. Now, what test do you guys want to order? This guy's acutely short of breath. He's tachypnic. Are his reflexes symmetrical? Yes, they're hyporeflexive, but symmetrical bilaterally. Good question. Now, what are you guys ordering? You guys have control of the orders, both lab tests and imaging. What do you guys want to see on this guy? CBC troponin, I agree. Good.
Ultrasound.
What was it?
Ultrasound.
Okay. What are you looking for with an ultrasound?
I would say distension of its iliac aorta. I'd also like to see that also closer towards his heart too, in case he's having an aneurysm. I'd also like to see if there's any fluid in his lungs or any edema.
Okay, good. So Josh said a chest x-ray and an echo. I agree with those. Definitely with the chest x-ray. What are you looking at for the echo, Josh? And CT for a head is never a bad sign, especially if a patient is unresponsive, and especially in an emergent situation. Good. I agree with all those. I think those are good tests right now. I agree with the chest x-ray, and I think the easiest thing that we can do, it's quick, get a chest x-ray. We can do a portable chest x-ray and do an anterior to posterior film in the patient's room very rapidly. The echo, that might be further down the line, but anybody else out there, what do you guys want an echo for? And this is what I want to start, teaching you guys now, is that you need to know what you're ordering these tests for. Like, what are you gonna do with the data when you get it? Yeah, you want to look at the ejection fraction and look and see how the heart is pumping. That's exactly right. Because this patient might have a reduced ejection fraction that's causing a shortness of breath, and may have a dilated cardiomyopathy. Hemodynamics of the heart. I agree with that. That's a great statement, a good blanket statement that says, looking at this, good. And you'll see this when you guys get into medical school, you get into residency, you'll see people say, what are you ordering this for? Why are you doing this? And that's, you have to kind of keep these things in mind when you work things up. Okay, so good. Excellent. Let's keep going here. So here's some more things. Here's our guy, and here's some more physical exam things. You guys may know exactly what this is looking at this guy. He is scoliotic. He has a little bit of bony abnormalities. He's very skinny. He has hyperextensibility. Also kind of, this is a sign of what this patient has, is when you kind of, it's a, I forgot what I think it starts with an S. I'll have to get back to you guys on it. I knew what it was called. It's like one of those eponyms where it's named after somebody in medicine. But basically, when you stick your thumb through, it kind of comes out on that side. Like when I do it, I have a little thumb, so it doesn't go through. But there's a genetic test that we want to test for in this gentleman. Does anybody have an idea? Oh, good. Somebody said it. It's Marfan's, exactly. So what we test for is fibrillin. And there's other things, other genetic causes of hyperextensibility, like Ehlers-Danlos syndrome is one of them, and that's a problem with collagen. It's a little bit different. There's another problem with collagen that's osteogenesis imperfecta. It usually affects babies. We kind of see that blue sclera. And things along those lines. But good, you guys are pinpointing this. This looks like Marfan's, which we know that in Marfan's, we can be, have a higher kind of susceptibility to different things, to cardiac things, problems with the valves, problems with the lungs. Okay, so good. Excellent. We're not going to spend too much time talking about Marfan's itself. There is a Marfan syndrome. You guys can look it up in terms of all the things that kind of go along with Marfan's. There's a lot. All right, so here's your guys' tests. Nobody said EKG, but I gave it to you anyway. Remember, in terms of the EKG, what we're looking at, and when we look at an EKG, let me move this plane. Constantly, all lecture, I have to move all my planes around. So, all right. So what we're looking at the electrical activity of the heart. That's what the EKG does. Okay. And you guys may know like ST segment elevation. I think that's all I knew when I was at your level. But what we're looking at is this electrical strip, okay? And when we see the P wave, so here's the P wave. The P wave is depolarization of the atria. So remember, if we draw the heart like this, here is, this is the right atrium, here's the left atrium, here is the left ventricle, and here is the right ventricle. Okay, so what we're looking at here is here's depolarization of the atria. So that's what we're looking at here. So here's the P wave. So when the atria depolarize, remember we start out with the SA node, which is the kind of pacemaker. Here's the AV node, goes to the bundle of His, and then the left and right bundles. Okay, bundle branch. So basically what we're seeing is the P wave is kind of the atria depolarizing. So it's kind of in this area right here. All right, then we keep going. Then we have a little bit of a Q wave. There's an R, S. Okay, then we kind of come back to baseline normally. And then there's a T wave. Okay, so this is called the QRS complex. QRS. And what the QRS is kind of the ventricles depolarizing. Okay. And in this, nobody really tells you this. And this is kind of like one of those party facts when you like, when you go, out in medicine, you could talk about, how when the atria repolarize, it's kind of hidden in the QRS complex. Nobody really cares about it, but it's happening there. But because the ventricles depolarizing have a larger electrical signal, the atria repolarizing for the next action potential kind of gets caught behind that. And then when the ventricles repolarize, that's what the T wave is. They're getting ready for that next electrical signal. Okay, so that's what that is. And now, knowing what you guys know, is that EKG normal or abnormal? You tell me.
I say normal because I see, PQRS waves.
Good.
And then, yep.
Exactly. So when I look at an EKG, and I'm not an expert by any means, that's why we have our friendly neighborhood cardiologists in a lot of ways kind of are truly experts in this, and electrophysiologists. What I look at is I look at rate, then I look at the rhythm, and then I look at axis, which is kind of if it's a normal axis or not. And we're not going to go too far into access, but if we look at the rate, what we're doing is we're dividing 200 by the number of big boxes. Okay, so we see like maybe 1, 2, 3, and this is probably like 4. Okay, so 200 divided by 4, that's normal rate. Okay, and then we look at the rhythm, whether these QRS complexes are happening regularly or irregularly. And to me, it looks like there's a normal time between each of these QRS complexes. So I would say that's a regular rhythm. Now, if one QRS complex was happening here, and then the next one was happening, here, and then the next one was happening here, that is irregular. We often see that in things like atrial fibrillation. Okay, so let me clear all this, and we're going to focus now, and that is a regular EKG, just so you know. What we're going to focus on now is this chest X-ray. Okay, and the way that I read chest X-rays is I use A, B, C, D, E as my mnemonic. Okay, and I'm going to move this up so that we can talk about it. So A is airway. So I look at the airway, see if the trachea is midline, which it kind of looks like it's, a little bit pushed to one side. So airway, B, bones. So I look at the bones, make sure they're not rotated, look at the ribs, make sure it's a good respiratory effort. But there's something screaming at us, and we're not going to be doing all this like calm, cool, collective things right now if we see this on our chest X-ray. And I want to see if anybody sees it before I kind of point it out. But if you guys see it, go ahead and point to it. You guys can pull out your pointers and go ahead and point to it on this this X-ray if you see it.
I think I do. The hardest push is pushed way to the right, and it's a bit enlarged, so it doesn't look quite right.
Good. So I agree with that. I think the heart is pushed to one way, but there's something on the chest X-ray. Remember, this is it's like we're looking at the patient right in front of us. So here is the that's the left side here. So this means that this is our right side. It's nice when they put the marker here. But look at our diaphragm looks okay. We could see our costophrenic angle, so there's no fluid in there. But when we look at airway and when we look at breathing, we see normal lung over here. We see normal pulmonary vasculature here. But on the other side, what do we see? Yeah, so Brenda kind of pointed to it, part of it. And I agree. So see how this lung is kind of obviously inflated. We see the vasculature here. We see all this, which is, pulmonary vasculature. Then we see kind of this right here. See the outline of the lung here? And you guys may be kicking yourself right now, which is okay. Sometimes, you like, for instance, the other day I was on Reddit reading the med school Reddit page, and there was like this thing, and it was this X-ray, and it was like it was just like a regular X-ray, and there was like, I forgot what the joke was associated with it, but there was no heart in the chest X-ray, and I swear I looked at it for like 5 minutes. I was like, I don't even understand what's wrong with this. And sometimes when you're looking too closely, you miss it. And that may be what you guys are doing here. So we'll see right here, this guy's short of breath. Yeah, the med school Reddit is good. You guys are probably all panicking with us during match week. So here is what we're seeing. You could see kind of the actual lung kind of drop there. Do you guys know what this is called? We see the lung dropped in. We could see it because of trauma. We could see it because of, we could see it spontaneously. But you guys know the kind of $5 word for this? Yeah, SEMA, exactly. Emily, you got it. It's a pneumothorax. You guys are right. So excellent. That's what this is. And you guys may know how to kind of fix this here. There is a video that I may or may not show you based on time. But what we're doing here is we are going to emergently, and the reason I said that, and anybody will tell you, if you're diagnosing a pneumothorax based on or off the chest x-ray, you may have made a mistake. And it may be not too late, but you may have made a mistake in that often this is a clinical diagnosis. And if you have suspicion that this patient has a pneumothorax, don't wait to get an x-ray. You're going to do this intervention kind of earlier. So what we're doing, and you know, the first thing is an emergent needle decompression, okay? And this is where anatomy is kind of our friend, okay? So the first rib is kind of up here. That was a horrible drawing, and I just screwed up that. The first rib is here, the second rib is here, and the third rib is here. And when we say intercostal space, break down the word: inter meaning between, and costal meaning ribs, okay? The second space is the space between the second and the third ribs. Okay, so what we're doing is we're sticking a needle in between the second and the third ribs, above the rib. Okay, remember that, because the neurovascular bundle and the meaning the vein, artery, nerve goes underneath the rib. Okay, so we want to avoid hitting all of those structures. We'll go above the rib. Okay, and that's what this image is showing here. Okay, so second intercostal space, mid-clavicular line. So the clavicle, and you can palpate these landmarks on yourself, okay? The clavicle, obviously, when you move up and down, the clavicle is going to move with it, okay? And the head of the clavicle will move when you extend and when you flex and extend your arm, okay? And mid-clavicular is kind of this angle right here. So right in the middle area. So here's clavicle, right in the middle, and then you can palpate. The first rib is a little bit higher, okay? So you'll feel it about here. And then you'll go lower, you'll feel your second rib, and then your third rib, okay? So in between the second and the third rib is where we're putting in that, that needle decompression. You know you've done it well when you hear that big gush of air. You can hear it kind of being released from that space, okay? And the reason why this is happening is we have air in the pleural space, which is a potential space causing the lung to collapse, okay? We'll go over an image of that in the following slides. But the definitive way that we're going to treat this is putting in a chest tube, especially if we need to. So let's see here.
This content is for this.
All right. Are you guys still able to see my screen?
Perfect. Yep.
All right. So let me show you this. And this is a doctor of whom does these kind of demonstrations on cadavers, which is cool.
We'll talk about some of the indications, the complications, and some of the potential pitfalls that you may run into. So what are the real indications of doing this? Well, it's to evacuate any type of air or fluid.
All right. I want to get to this part here. Hopefully it gets to it.
And then pull the suture together and close the wound.
All right. So what we're seeing here is he's putting in a chest tube, okay? And what he's doing is, here's the axillary line. So remember axilla kind of this way. What he's doing is putting in a chest tube as the definitive way to drain excess air, fluid. So if somebody had a hemothorax, which is blood in the pleural space, we might put in a chest tube to kind of release some of that, that blood, some of that air that's in there. And we do this at the fourth or fifth intercostal space at the mid-axillary line. And a good way to kind of tell is the nipple is often at the fourth or fifth space. And this could be different depending on, a lot of different factors. Though to be space, we want to go, or safe, we want to be a little bit higher, okay? Now, let me try to move my toolbar here. Okay. Okay, let me get to where he's kind of putting in this tube. And you guys can go and watch this. But what he's doing is kind of making this insertion here, and he's going to kind of go in with these clamps and kind of penetrate the pleura. Okay, and that's what he's doing with these Kelly clamps here. He's going in, penetrating the pleura, sticking in that chest tube, and you'll often you'll hear some air, you'll get some drawback of fluid. And then another thing to remember is if you stick in a chest tube and you get a lot of fluid over a 24-hour period, or a large amount of fluid initially, and that's a good indication to do a thoracotomy, so kind of a more invasive procedure due to that, excess fluid and air being there. Okay, so that's what we're doing. We're putting in this chest tube, then we kind of suture it in place and we leave it in for a certain period of time, monitor the drainage as a result. It's kind of a cool video if you want to watch it. He is doing it on a cadaver, so like don't be fooled. This patient's not like just sleeping there. So those are people of whom have donated their body to science, which I always think is really respectable. It's really cool. Let's keep going here. Let me get back to figure out how to get back. All right. Perfect. So those are the two videos. You could certainly go back and watch them. They're like 10-minute videos, 5-minute videos if you put them on 2x speed. But nevertheless, it shouldn't take you too long to kind of go through those if you so please. But remember, this is going to be a question on your quiz here in a few minutes. If you do it tonight, is the initial emergent thing to do is do the emergent needle decompression, kind of get rid of that space, expand the lung back. And then the kind of definitive thing is putting in that chest tube, 4th or 5th intercostal space at the mid-axillary line. So remember the difference is the needle decompression is at the mid-clavicular line, so that's anterior, and then the mid-axillary line is kind of lateral. Okay, so great job.
This content is for educational purposes only and is not.
All right, so now let's talk a little bit about a pneumothorax in general. We're going to kind of talk about this as a cause of dyspnea. Okay, so first, what is it? It's inappropriate air in the pleural space. And remember that the pleural space is only a potential space. You may have learned this in anatomy so far. And remember what it is it's a, here's the lung, obviously. And the pleural cavity is a space between the visceral, meaning whenever you hear visceral, that's the part actually attached to the organ. Visceral meaning, that's kind of an organ attachment. Parietal is usually always the outside. And what the pleural cavity is a space between the parietal and the visceral pleura. Okay. And when air gets in there, it expands that space and collapses the lung. Okay. And that's why we got to emergently stick in that needle to kind of expand the lung back. And what this does is it can impair ventilation. Remember, our patient came in with shortness of breath. And despite, having these intercostal muscles, being able to physically try to take a deep breath, that air is inhibiting the full expansion of the lung. Okay. What causes it? It can be spontaneous, meaning, you and I, healthy people, can just spontaneously collapse a lung. I remember when I was in my internal medicine rotation, I had a patient there of whom had a spontaneous pneumothorax, wasn't a Marfan's patient, didn't really have any risk factors, was a runner, really active, and had a spontaneous pneumothorax. It was a small one. And sometimes if the pneumothoraces are small, we could treat them just with oxygen, and we won't have to put in a chest tube or put in a needle decompression. Sometimes it'll spontaneously also go back. Tension, meaning there's tension on the lung. So that can be primary in terms of it's a lung cause in and of itself, or secondary due to something else. And you'll see in a tension pneumothorax, the important thing to kind of draw your attention to here is that in a tension pneumothorax, what's happening is because of the collapsed lung, we're getting tracheal deviation, and we're getting increased intrathoracic pressure. So there's so much pressure that we're getting decreased pulmonary return. We're getting a shift of the heart and the trachea to the opposite side. And because of that increased pressure, we're getting decreased decreased blood returning to the superior vena cava. And as a result, we get hypotension. And when we get hypotension, the correct hemodynamic compensation would be tachycardia. Okay, so because of that pressure, we get decreased venous return to the heart. So not as much blood going back to the heart. We get hypotensive. And then as a result, the heart says, okay, I'm not getting blood where I need to. Let's increase the heart rate to try to compensate for that. So that's what's happening. That's also a question. So remember that we're getting that decreased venous return and as a result, hypotension. All right, and how do these patients present? They present with shortness of breath. That's what we're talking about today. They may get chest pain, an acute onset of chest pain. They may get tachycardia, which we just talked about, and they may have hypotension. So remember, we talked about all these things and why these things are happening. So let's keep going here. Now, this is going to be kind of our summary slide, and we're going to talk about a few other things as to not take up, too much of your time here. But remember, the whole thing being that there's many different differential diagnoses for chronic dyspnea. Okay, it could be pulmonary in nature. It can be cardiac, it could be gastrointestinal, neuromuscular, it could be, things like anemias. Okay, I'm going to show you a few chest x-rays here on the right-hand side. And I want you to see if you can point out any of what's going on. But let's start with this first one here. What do you guys see? Is pneumothorax the same thing as a collapsed lung? Yes, it is. It's a cute fancy word for collapsed lung. Exactly. So yeah, we do see some blunting of the costophrenic angle. I think you're right. So yeah, a little bit blunting, but we see it on one side. So remember, this is our left side, and this is our right side. So, but somebody circled it, but I didn't get to see who circled it. No clear diaphragm line. Did you spell it wrong? It looks right to me. I don't know. I'm not a linguistic person. And whoever circled it in green, you can proudly say that you're right. You can send a shout out in the chat, say it was you, because you deserve credit. You're absolutely right. I would circle that same area, and this patient, yay, you did it. Adrika, I hope I said your name right. You did it. That is what I would call a pneumonia there. Okay, it looks like it's on the right side. We might call that right lower, maybe right middle there, but it looks like probably right lower lobe pneumonia. That patient may come in with cough. They may come in with shortness of breath. So that's right along our theme today. All right, so let's look at this one here. Remember, this is our left-hand side. What are we seeing here? Okay. If you guys have an idea of what this may be associated with, go ahead and shout it out. But what we're seeing when we look at the airway, okay, we see a good airway. We see a good kind of tracheal bifurcation of the trachea there. We see a skinny cardiac silhouette. We see good costophrenic angles here. We see no blunting of them with fluid or anything. But what we see is huge lung volumes. Do you guys see that? We see, a lot of ribs. If we counted them, we would probably say, okay, 1, 2, 3, 4, 5, 6, 7, 8, 9, maybe 10 ribs in this field. So knowing what you guys know now, where would you see, we see that the lungs are expanded. So don't say pneumothorax. I don't want you guys to think I'm trying to point you in the same direction. But we see increased lung volumes. We see dropped diaphragms. We've talked about this in another one for the people that were there many moons ago. This patient may be a smoker. Or may have been exposed to chronic solvents over time. Yeah, good. COPD. So with COPD, what we see is we see dropped diaphragms, we see increased lung fills, we see many ribs in the fill, we see a skinny heart. So good job. You guys got that one. That patient often has chronic shortness of breath that we treat with antimuscarinic drugs, albuterol sometimes, and pulmonary rehab often too. Okay. So now this one you guys shouldn't miss. The top X-ray here. What do you guys see in that one? Yeah, good job. A giant heart. So sometimes in a congenital thing, it might be called like a water bottle shaped heart. That's usually associated with a congenital malformation and atrial septal defect. But on this, remember, this is what I drew for you, but it wasn't this pretty when I drew it for you. This is a normal EKG kind of electrical activity here. Now, when we see this patient's EKG here, what do you guys see? Remember, when we see this PQRS, the S should come up and it should be kind of, flat for a minute, kind of go back to baseline, then we should see the T wave. So we see in a few leads, we see maybe in one, we see it often in two, maybe not so much three, but V1, we see it definitely in V2, V3. When we see kind of elevation of, here's the S and here's the T. So what we're seeing here is there's the P, here's Q, R, S, and then what we're seeing is kind of this. Okay, here's a horrible T wave here. So what we're seeing, here's the ST, and what is between it is the ST segment. So when we see that kind of elevated there, we call that ST segment elevation, okay? But we're seeing it in a lot of leads. We're not seeing it anywhere that's corresponding to acute coronary syndrome, okay? So we talked about in another lecture where, if it's 2-3 and AVF, that's an inferior myocardial infarction, or if it's in AVL, V5, V6, that's lateral. But we're seeing it in a lot of leads. So we're seeing diffuse ST segment elevation. If this person told me that they just had a viral infection, I would say that this is an infection of the heart. Do you guys know what that's called? Yeah, pericarditis. So we could also have myocarditis, but this one is pericarditis that we're seeing here. Okay. And now in this echocardiogram here on the bottom, we're seeing kind of dilatation of the all the chambers of the heart. This patient may, the history we may get from this is they may drink a lot of alcohol, or they may have a viral syndrome that they had and now have dilated cardiomyopathy. Okay, but what we're seeing is, so here is the left atrium. Okay, here's the left ventricle. Here is the right ventricle, and here is the right atrium. I don't know why I drew an A before the R. But here in this area, what we're seeing is we're seeing kind of a small septum. We should see a thicker septum, more musculature in this ventricle. Remember, the ventricle, the left ventricle specifically, should be big and beefy. You probably remember this from your anatomy class. If you don't, that's okay. But remember, the left ventricle is the one that's pumping pretty hard in order to resist systemic pressures to pump into the rest of the body, into the aorta. So it's usually bigger, beefier. And here we're not seeing that musculature. So we're calling this cardiomyopathy, dilated cardiomyopathy. Okay. So good. That's what I have for you guys. Remember, here's kind of our algorithm, and really the path that we kind of talked about was this. We talked about, we got the history, they were hyperresonant on percussion, we got a chest x-ray, but we probably could diagnose that for, even before. We assessed for hyperinflation, that patient was hyperinflated. And we didn't see a low cardiac output. We didn't have signs of that. But what we did see is acute shortness of breath in somebody that was otherwise well, kind of pointing us into the direction of a pneumothorax. And sometimes you might see it abbreviated like this, PTX. But remember, this could have gone a lot of different ways. We could have got that chest radiograph, and we could have saw a lot of fluid in the lungs, which pointed us in the direction of a pleural effusion, which is fluid in the lungs. Okay, and you know, when we have fluid in the lungs, that might point us in the direction of cardiogenic versus non-cardiogenic pulmonary edema. Okay, so this could have went a lot of different ways. So there's my whole point being is when you're approaching shortness of breath, there's no kind of this is what you do. You have to take into consideration the history. You have to take into consideration the physical exam and kind of take a direction that makes most sense based on what your patient has. Okay. So that's what I have for you guys. And before you all go, I want to give you the post poll, and let me relaunch it for you. So go ahead and fill that out there. And after this is my last slide. So after this, I'll stick around for a little while and you can ask any questions you may have about medical school, about getting into medical school, about this essay, about residency, about whatever you guys have, any questions or anything. And I think the next time, I'm not sure, I think you're doing like congenital things, next lecture, but I think most of you guys are in. Let me share the results here. So it looks like most of you said you know a little bit or you know some, which is great. 64% of you said you know some, and nobody said they know nothing, which is always good. I'd be a little bit sad if you guys said you knew nothing. But thank you guys for coming. I really appreciate it. This is always, you know, one of my favorite parts of my week when I get to teach you all. As I kind of said, I will stick around for a few minutes and answer any questions you guys have about the lecture or any questions you have at all in general. So thank you again for coming. I always appreciate you guys coming and being attentive and answering questions. Can high schoolers also attend these meetings? Yeah, I don't see any reason why not. You guys definitely can. You guys could definitely come. I think that, you know, that gives you good exposure to medicine from an early age, and you know, just don't feel kind of bad if you don't know a lot of kind of the physiology or pathology or anything like that. I think you know, that it's totally okay if you you know, don't know that stuff. I try to, you know, keep it pretty simple and kind of go through it so that you guys aren't too lost. Cause I know that, you know, when I was at your guys' level, I always felt like I didn't know anything, but it kind of comes with time. Now, Seema asked about the echo image. She said, how do you know that there was, that the top was a ventricle and not an atrium? So I'll tell you a few reasons. And the main reason is because of the way that because this is the way that this is one of the ways that we look at the heart. So this is a long axis, and basically an echocardiogram is just an ultrasound of the heart. Okay, but the way I know is because of the positioning of the probe, number one, and two, the atria are always smaller than the ventricles, so like kind of simplistically put. Okay, so we know that this is the atria down here, they're smaller. And then here we know these are the ventricles because they're a little more musculature, they have a little more musculature. The ventricle looks big also. Yeah. So, I mean, this side it looks like part of it's cut off, so it probably goes like this. And then the atria a little smaller, a little more rounded. And then the ventricle should have a little more muscle, but this is a dilated cardiomyopathy anyway. And these atria are in fact dilated. So that's a good question. The atria are dilated because this is a cardiomyopathy. But based on the positioning of the probe, you'll know that this is a, or the echo tech will know, or your cardiologist will know that this is atria on the bottom and ventricles up top. That's a good question.
I have a quick question.
Yeah.
I'm wondering, how does the patient's family history fit in? So like, could it have been a sign that his dad died from this aneurysm to indicate that, you know, maybe something is serious is going on?
Yeah, good question. And we didn't really touch on that at the end. I'm glad you brought it up because I put it in there for a reason. And his father died from an aortic aneurysm. And what we kind of talked about later on was that this patient had Marfan syndrome, which is certainly a genetic disease. So maybe this patient's dad also had Marfan syndrome, but you're going to kind of find when you ask about histories, you have to really kind of go into details and kind of uncover things. Okay. So this patient's dad died from a thoracic aortic aneurysm. And when patients are young and have aneurysms and didn't smoke and are fairly healthy and they're tall and skinny, that kind of points us in the direction of Marfan syndrome. So what I was kind of trying to allude here is that this patient's dad may have had Marfan syndrome also. And this patient definitely looks like a Marfan syndrome patient. And now that you guys have seen this, you'll probably see, you know, maybe you'll see patients out there of whom have Marfan syndrome. They're tall, they're skinny, they're kind of lanky. They look like they would be great basketball players. They have that thing. It starts with an S. I really can't think of it right now, where they stick their thumb through. Another thing is, you know, if you're really skinny, you could do this. And right now I can, probably because I'm dehydrated, but when you stick your, you could kind of make stick your thumb and I think it's pointer finger, but I can't do it. Thumb and pointer finger. It's not middle finger, pointer finger. And then they're so skinny, they can stick, you know, that around. That's another sign. The hyperflexibility, all those are things that lead to aneurysms, which point us in the direction that we may need to do genetic testing, and can lead to a spontaneous pneumothorax. Now, with our patient, if they had Marfan syndrome, does that change the way we treat them? Not for a pneumothorax if they're presenting acutely, but if we know that this guy has Marfan syndrome, do we want to check for an aortic aneurysm also? Probably as an outpatient, if this patient is in the emergency room. So, you know, we do have screening guidelines to screen for aneurysms in patients of whom are smokers, but someone with a congenital abnormality or of the heart or with genetic syndromes, maybe we'll want to screen them earlier, especially if they had a parent of whom died of an aortic aneurysm. Does that answer your question?
Yeah, for sure. Yeah, I guess you're kind of showing that a person's history does not always like directly give you the answers, you know, like the father wasn't diagnosed, like he probably died too young, but when you get clues and then you try to piece things together.
That's right.
Yeah, it's really, really interesting.
Yeah, and that's what you're going to see, you know, when you, you know, start to get into clinics and when you get into medical school, you're going to start to see that not everything is significant, but you got to kind of take in all the information. You got to sort through it and say, you know, this might be something, you know, maybe this is something, this is not that important. But anytime somebody dies of something young, you know, for instance, something that is common is aneurysms in the brain and kidney disease. So if somebody, you know, died suddenly of an brain aneurysm, maybe they had autosomal dominant polycystic kidney disease. So maybe, we want to screen their relatives to see if they, also have
Oh,
that.
wow.
So, it's just kind of taking things into consideration and connecting the pieces. And yes, you're right, deciding what's important and what's not important, because not everything somebody tells you is going to be important. And, you could get caught in the weeds if you start focusing on something that's not as important. Okay.
Yeah. Okay. Thank you.
You're very welcome. Good question.
Are you in internal medicine?
So I am starting my residency in internal medicine in July. So I'm going to be moving to Portland, Oregon, and starting there. But yes, you probably have caught on. A lot of my lectures are all in internal medicine. So that's what I like, and that's what I like about internal medicine is you have to really kind of piece together different things and decide what's important and kind of run with it and take into consideration a lot of different parts of the body. So it's kind of a cool field, I think.
Yeah, sounds exciting. I always like to ask people what were like the sort of determining factors for choosing their specialty, because it's always interesting to hear new things that you've probably never considered.
Yeah. So for me, I went into medical school thinking that maybe I wanted to do pediatrics or I don't know. I thought pediatrics for a long time, but I found later that I like kids, but I don't like pediatric medicine. It's a lot different than just kids. There's lots of factors to it. So, and I found later on that I liked almost every block in school, which was like hard for me to be like, oh God, like now what? I like everything. So, I thought
Whether you like everything or you don't.
That's right. Yeah. And then the other thing is I found that I didn't like learning about pediatrics as much, and I didn't like learning about OB/GYN as much. So that really kind of funneled me into the internal medicine category. But, I was always the type of student in school where I always tried to learn as much as I can all the time. So I wanted to kind of make connections to other things. And when I was in my GI block, I wanted to make a connection to, something that happened in dermatology or GI or whatever, so that kind of pointed me in that direction. And then I had good experiences when I was in my internal medicine rotation, so that kind of reaffirmed it for me. And I like kind of the prospect of managing sick patients in the hospital, and I'm considering doing maybe a fellowship down the line in pulmonary and critical care. So internal medicine is the path to that. Otherwise, I might, be a hospitalist. And I think it kind of fits my personality and my interests, closely. So I thought it was a good decision for me.
Well, nice to hear what people are considering.
Yeah, and don't be thrown off if you don't know right now. It's totally fine. You don't need to know at your level. I thought I wanted to do hematology, oncology, maybe family medicine, maybe pediatrics when I was at your level, but as you can see, I'm not really doing any of that. And you'll find, and you'll be kind of pointed in the direction. You'll have lots of experience in medical school that either kind of confirm or deny your suspicions. But regardless, it's always good to kind of keep keep an open mind when you're going in, because if you do that, you'll be pretty impressionable throughout your education, and then you'll end up being somewhere that you're really interested in.
Thank you so much.
Yes, you're very welcome.
Yeah, thanks.